Good morning. My name is Kathy Crane, and I'm the Executive Director of the American Parkinson Disease Association Greater St. Louis chapter. On behalf of everyone at APDA, the St. Louis, Oklahoma, and Midwest chapters, we want to welcome you to day 2 of our Midwest Congress. We had so many wonderful comments yesterday in the chat. I would like to keep it going. If you attended day 1, would you go in the chat and tell us your best takeaway? And if you're new to us today, perhaps you could put in there your name and where you're from so we can get to know each other. While you're doing that, I want to tell you a little bit about the American Parkinson Disease Association. Our mission is to provide support, education, and research to help everyone impacted by PD live life to the fullest. To that end, we offer a wide array of programming: physical and mental exercise, voice, dance, art, meditation, and our signature press program and support groups. When it comes to education, we offer programs like the one today, and also individual presentations, interviews, Dr. Gilbert's blog, and just a wide array of resources that are available to all of you. Absolutely everything is free. You can find out more by contacting our chapters. The 3 sponsoring chapters have links on this page. You can actually go there to find out more, or you can go to the national website to find a chapter, information and referral center, or Center for Advanced Research that's near you. We really welcome your calls and inquiries. We're here for you. So we want to be with you through your PD journey, and I hope you will connect with us. It's an honor to be able to thank our sponsors for today. Our good friends in St. Louis are our presenting sponsor, the James and Allison Bates Foundation. They are true PD heroes. Thank you, James and Allison Bates Foundation. Our champion sponsors, the JCA Charitable Foundation, here in St. Louis, they partner with us on all our educational events. And new to the champion, Synovian. Thank you so much. Our collaborator sponsors are AbbVie, Acadia Pharmaceuticals, Adamas, Amneal, Boston Scientific, Delta Dental, Kiowa Kirin, and Medtronic. We are really grateful. To learn more about the sponsors, you can link to them right on this page. You won't miss any of the presentation. That will show while you're looking at their page. So go ahead and multitask, and you can go there. Okay, it looks like many of you are writing who you are. Jane Murray sends greetings from Diamond, Missouri. Wonderful. Lori Morris-Witt says hello from Oklahoma. I know you were on yesterday, Lori. That's great. Oh, and Tom Butler. I just talked to you on the phone, I think last week. Welcome, Tom. This is wonderful. I do want to make a special shout out to all of you that are here today. You're so important to us, and especially those of you who took the time and thought about when you were registering, you also made a contribution. I can't thank you enough. To all of us, you send such encouragement with that donation and with your notes. Thank you for thinking of paying it forward so that this free programming can be available to everyone. We're really grateful to you, and it means a lot. It really means a lot. So we have a wonderful lineup of speakers today. We hope that you find this event to be empowering and helpful in your Parkinson journey. I really want to thank you for joining us. Next up will be Dr. Michael Mercury. He comes to us from the Midwest chapter, and he's going to share more about depression and anxiety in Parkinson's disease. Oh, Karen Frank just said hi. Hi, Karen. I know you were on yesterday too. You have to put your favorite part of the program yesterday. Really, I know you were there. I saw your questions. Okay, so anyway, Dr. Mercury will be here, and we have many more. Oklahoma has Dr. Clausen coming on later today. I hope you'll stay through the whole day. Have a wonderful time. Please connect with us. I don't think we have any more questions, so I hope you have a wonderful day. Thank you.
Good morning, and thank you, Kathy, for your kind words. My name is Michael Mercury, and I'm going to be talking about depression and anxiety in Parkinson's disease. And please feel free to put any questions that you have in the live chat, and I'll address them during the Q&A today. All right. So as far as disclosures go, I really don't have any specific ones. I'm an employee of Northwestern Medicine Healthcare, and I have an academic appointment, and I have some grant money from our foundation. So we're going to talk about the neuropsychiatric disorders, depression and anxiety. And there's always a challenge in working with depression and anxiety, and part of that is based on the history. So I'm going to review real briefly with you why there's still, unfortunately, a stigma attached to depression and to anxiety. Originally in medicine, the mood disorders were relegated to what we call functional, meaning they weren't real in a sense. And you see my title up there, weakness of character. They were almost associated with that. So, you know, pull yourself up with your bootstraps, get over it, that sort of thing. And fortunately, because of the specialties of neurology, neuropsychiatry, which combines psychiatry and neurology, and actually neurosurgery, we first of all got to learn that the brain controls our thoughts, our feelings, and our actions. And beyond that, we got to know that certain neurological disorders like Parkinson's disease change the biology of the brain and influence our thoughts, our feelings, and our actions. So my point is, these are real diseases, and we need to approach them in that manner. And that's going to be kind of the theme here when we go over each of these topics. But let's do a little bit more history. And we have Dr. James Parkinson's, who was really ahead of his time. And I think a lot of you have seen the quote that he gives on the motor. But here's the quote, first of all, on depression. So he got a patient from Dr. Mady, and Dr. Parkinson writes, "A more melancholy object I never beheld." So there he is describing depression. We think he's describing anxiety when he talks about apprehension, and he has a description of apprehension associated with falling and gait. So we think that reflects anxiety. So again, he was ahead of his time in that manner. Now, what are we talking about when we talk about anxiety and depression? When we talk about Parkinson's, we can think of the motor and we can think about the non-motor. And so the motor, of course, are the more obvious symptoms involving things like tremor, slowness in movement, rigidity, and so on. And the non-motor range everywhere from depression, anxiety, constipation, sleep disorders, and so on. So today we're focusing on two of the non-motor aspects or symptoms. The other thing that's important about them, and if you look at this slide here, is that actually these non-motor symptoms often will predate the more obvious symptoms. So you might have anxiety as the first symptom that is actually indicating that you've got the beginning of Parkinson's disease, or constipation is another one that can sometimes be one of the first symptoms that come up. So we're going to start by talking specifically about depression in Parkinson's disease. And I want to put that in a little bit of context. Let's look at how pervasive depression is in neurological disorders and in certain populations. And if you look at stroke right here, 47% of people with stroke have depression. If you look at a heart attack, myocardial infarct, 45%. And then you've got Parkinson's disease, right around 40%. So depression is common in many, many diseases, and also it's common in certain populations. So if you look at geriatric inpatients, which we typically define as 70 and older who are in the hospital, it's about 36%. Now, if we look at what is depression in Parkinson's disease, if we look at the etiology, there's different ways we can look at it. One is that it's comorbid or it coexists with the Parkinson's disease. So in the first example I've got up here, this would be somebody who's had depression, maybe even as a teenager, lifelong depression. So whether they had Parkinson's disease or not, they would have depression as a diagnosis. They're suffering from that disease. This is somebody who's got more of what we call a reactive depression. So whether they had Parkinson's disease, whether they have cancer, whether they've had a stroke, they get depression. It's not specific to Parkinson's. But then there's a third option, and that is, and what I see in patients, this is somebody who's never had any depression their whole life, all of a sudden has adult onset depression. And remember, depression can actually predate the motor symptoms. So they've got new onset depression. And now we think that it's actually part of the same pathophysiology that's causing the motor symptoms of Parkinson's disease. So it's a non-motor symptom. It's part of the Parkinson's disease. Now, I've got an asterisk up here because depression's important. I want to make another point. We're talking about the patient with Parkinson's disease, but let's not forget the family caregiver. The family caregiver actually has at least a 20% chance of getting depression themselves. And when I talk about some of the things that depression can do, remember that can be affecting loved ones as well, not just the patient. And if there's some dementia on board, being a family caregiver increases your chances of depression to 60%. And this one researcher, Gallagher, just did a study, what's COVID doing to all of that in the background, of course. And these same family caregivers now are attributing loneliness, which is actually something that we're measuring separately from depression and anxiety, but loneliness as a cause of depression in the caregiver. So be aware of the family caregiver, that's important. And that's why we've got great social workers who help with Parkinson's disease. It's not just the patient, it's the family. So let's next look at what's the formal definition of depression. And I'm quoting here, or actually paraphrasing from the Diagnostic Statistical Manual, 5th edition. And this is what the psychiatrists use. And these are consensus statements, basically. Unfortunately, there is no lab test that we can order in order to say, oh, you have depression, or oh, you've got anxiety. So it's a matter of, do people meet certain criteria? In a way, it's not that different than some of the limitations we have in Parkinson's disease, which is still a clinical diagnosis. Yes, we've got some things that can help, like the DAT scan, but for definitive diagnosis, you need a specialist, and you need them to follow certain guidelines to say, yes, this is Parkinson's disease. So depression has also those limitations. So if you look at the statement, we have to have symptoms for at least 2 weeks. It's got to be more intense than the normal fluctuations. And then there are these criteria, either depressed mood or diminished interest or pleasure. You have to have one of those. And then you've got to have 3 to 4 of these other symptoms. But let me bring you down here. And what does it say? It cannot be due to a medical condition. So today I'm talking to you about depression in Parkinson's disease, and I just gave you the formal definition that says depression can't be due to a medical condition. That just shows you one of the limitations of the definition. So what are the typical symptoms of depression in Parkinson's disease? They don't quite meet those criteria. What we more commonly see is anguish, irritability, anhedonia, which is just the inability to feel pleasure. You do a great job at something and you don't get that reinforcement. A decreased interest in activities, pessimism regarding the future, You get some suicidal ideation, which is thoughts of suicide, different from actually attempting suicide. And you get anxiety. So in about 14% of cases, anxiety and depression actually go together. What's less common, and these are the other areas I did not specifically go through that are part of the DSM-5 symptoms with depression. What are less common are guilt, feelings of worthlessness, self-blame, and suicide. So is there a risk of suicide in Parkinson's disease? Well, we don't think so. It seems that the rate is about the same as the general population, and this is the US population, which is just a little greater than 15 per 100,000. There's been some literature over the past probably 15 years now that maybe DBS increases risk of suicide. Specifically if it involves the subthalamic nucleus. This has not been confirmed. We take all sorts of precautions when we are examining somebody for DBS. If they're depressed, we get that treated. If they're suicidal, certainly we get that treated, and so on. So think of this as still being evaluated in a sense. My personal experience, and we have a robust DBS program, is it has not been an issue, and I've been working with DBS since 1997. But it's in the literature, so we're keeping an eye on it. Now, again, with the pressure of COVID and everything, and with the fact that some people with Parkinson's, as I said at the beginning, might have depression that's not related to their Parkinson's. They just have depression. I just want you to be aware there are these 24-hour, 7-day-a-week hotlines. There's a National Suicide Prevention Lifeline, and there's the phone number for that. And there's even a crisis text line. And many local hospitals also have 24/7 hotlines that you can call. So talking about suicide is a whole other lecture that I don't have time to do today, but be aware there is help out there if there's any concern about it. And if you're worried that a loved one is suicidal, you will not cause them to commit suicide by asking. You ask, and if there is a crisis, either call a hotline or even 911 if you need to. So let me go on to what are some of the challenges in diagnosing depression in Parkinson's disease. Why is it missed? So it's sometimes missed because some of the same characteristics that we see in depression, we see in Parkinson's disease. Very common, masking of the face. And that can look a lot like what we call a blunted affect, where someone with depression doesn't show much expression. There's a decrease in the spontaneity and speed of movement and reflexes in Parkinson's. We call that bradykinesia. What do we get in depression? Psychomotor slowing. And I'm going to quote William Styron, who talked about his own depression. He was a novelist. And he said, soon evident are the slowed down responses near paralysis. Ultimately, the body is affected and feels sapped, drained. And I'm quoting him because, number one, I think he says it the way it is. But again, I just want to underscore that this is a disease that needs to be treated as seriously as any other disease. Depression is not in any way a weakness of character. It is a disease. Both of them cause sleep disorders, poor sleep efficiency, meaning how long are you in bed and how much sleep did you get? Decreased sleep time, early morning awakening, that can be either one. Both can cause decreased appetite. So if I've got somebody with those symptoms, I may say, well, that's part of the Parkinson's disease. We don't need to do anything further. And that's where it's important to dig deeper. Now, how do we do that? How do we diagnose it? Well, as I said before, we don't have a nice lab test, which would be great. So we rely really on the clinician doing an interview or some sort of a questionnaire. The first example I'm giving you here is a face-valid self-report measure. That's something like the geriatric depression scale. There's a 15 item, we hand it to the patient, and it's got yes or no questions. Here's the problem with that. If the patient, again, believes this is weakness of character, they're going to deny any of the symptoms that we're asking them about. Because the reason we call it face valid is it's asking questions that if you answer it in the yes direction, it's going to say one thing. If you say it in the no direction, it's going to say another. So you could make it look like you are depressed or you're not depressed. The other problem is if someone has the beginnings of a dementia, that can affect their responses. So there's some limitations with these questionnaires that the patient fills out. Observer rating scales, unfortunately, are in their infancy, but these would be so helpful. In other words, a spouse, adult child, filling out a form saying, mom or dad with Parkinson's disease have these symptoms. But we've only got one right now, and we need more. But the input we get, I do formal interviews with relatives or family caregivers. That gives me a lot of information as to whether or not there is depression present. And then we've got the structured interview. The structured interview is very good. It's usually the doctor asking questions to the patient, and this allows also follow-up questions, clarification, and so on. The main limitation is the amount of time it takes. So unless the visit is specifically to evaluate depression or anxiety, it's hard to fit in a full exam, a motor exam, and maybe a cognitive exam, and to use something like a structured interview all in one setting. So those are not used as much as one might hope. So hopefully things will improve, but we really rely on the questionnaires and also on what family caregivers can tell us as well. So next I want to talk about how does depression change the way people perceive the world? People with depression often say they experience the world differently. And one of the things that I found really striking is they'll often say time seems to drag on. And this altered perception leads to feelings of hopelessness and feelings that they're not in control of their lives. And here's William Styrone again. In depression, faith in deliverance in ultimate restoration is absent. The pain is unremission, intolerable, is the foreknowledge that no remedy will come, not in a day, an hour, a month, or a minute. It is the hopelessness, even more than pain, that crushes the soul, nearly immobilized and in a trance of supreme discomfort. So again, just underscoring this is a disease. And my last point on this page, it actually causes increased pain sensitivity. So someone who's depressed feels pain more than someone who's not depressed. So if someone's got the curling of their toes when they go to bed at night and the pain that often accompanies it, that's going to hurt even more if they have active depression. The good news is depression is treatable, and Mr. Styrone was treated and successfully. But it is a challenge, and it needs to be diagnosed when it's present. Now, depression on top of this can exacerbate symptoms of Parkinson's disease. Now, we know Parkinson's disease is a neurodegenerative disease, and so it gets worse over time, gradually. If somebody has depression on top of the Parkinson's disease, my goal is to get that depression treated because it's going to alleviate some of the symptoms that the person is experiencing. And let me go through cognitively what goes on. Parkinson's causes executive dysfunction. So that's things like how quickly I can process information. Doesn't affect my intelligence, but I go to do the checkbook and it's taking me twice as long to do that arithmetic in my head. And maybe it's taking me 3 times as long. And maybe I get frustrated and I say I can't do it. Well, technically I can still do it, but it can be frustrating. If I've got depression, instead of it being this much of a problem, it's this much of a problem. I can treat the depression. I'm going to increase the speed of processing. So very important to be aware of that. Retrieval memory problems, the same thing. Very common in Parkinson's disease, having difficulty recalling something. So you ask me a question and I can't really remember it at that moment, and it comes back to me later, or you give me a reminder and it comes back to me. Depression does the same thing. My memory is going to be worse if on top of the Parkinson's, I've got depression. And then the other thing, we can see apathy in Parkinson's disease. Well, apathy is going to be made worse if we've got the lack of motivation that we see with depression. So again, we want to treat that depression. Same thing physically. Physically, if we've got the burden of depression, it's going to make some physical areas worse. Psychomotor slowing that we've already talked about. You're going to be even slower if you're depressed. Sleep disorders. And this is one that a lot of people don't know. You get reduced sensitivity to visual contrast in Parkinson's disease. You also get it in depression. In depression, it's reversible. So we treat the depression, we should at least temporarily improve the vision. So we want to be aware of that. But here's the challenge with treatment. The challenge with treatment is there's no specific guidelines. Number one, it's multifactorial. It depends on the patient's medical status. It depends on the severity of the depression. We always take in the patient's preference for treatment. And it also depends on the neurologist's expertise in treating depression. So most of the movement disorders neurologists with whom I work will treat depression to a certain extent. Or the psychiatrist's expertise in Parkinson's disease. And many psychiatrists will not see patients who have Parkinson's disease. They're just not comfortable and not trained in Parkinson's disease. Now, if your area has a neuropsychiatrist, they are psychiatrists trained in neurological disorders, including Parkinson's disease, and they are very, very good with treatment. But here's our treatment choices. Look at the first one, exercise. And I'm sure your movement disorder specialists, what's the one thing they tell you that we should all be doing is exercising. So exercise helps with Parkinson's disease. Another bonus is we believe it helps either delay or possibly prevent Alzheimer's that we're all at risk for, because the biggest risk factor for Alzheimer's is age. So exercise, number one. Number two is medication. And here's where it gets a little controversial. There are some medications that are very promising, but then there are sometimes side effects. So again, that's going to depend on the neurologist and the patient as to which medications are tried first. Cognitive behavioral therapy has a lot of evidence that it is helpful. It's a nice alternative without having to add one more medication, as people are often on several medications. Repeat transcranial magnetic stimulation, or TMS, is another area that looks very promising for depression. Electroconvulsive therapy for treatment resistant is used. And a new area, relatively new, by Dr. Helen Mayberg, who's a neurologist, is using DBS actually for treating depression. Now, this is still experimental. It's interesting, some of the areas for depression are close to the areas where we go in for treating the Parkinson's disease. So I think stay tuned. There might be something helpful here where DBS perhaps someday is able to do something that would help with both motor and with depression. But right now it's just in the research stages. So next I'm going to talk a little bit now about anxiety in Parkinson's disease. And I'm going to start with just reminding you of these two slides. So again, anxiety, if you look at the slide here, is one of the non-motor. And the other thing, again, is that anxiety can predate any of the obvious motor symptoms that we see. So what is anxiety? I mean, just generally speaking, it's our fight or flight, but it's activating when there's nothing we need to fight or flight from. There is no fear-causing stimulus present. It affects about 40% of people with Parkinson's, and it may predate the motor symptoms by some 10 years. I mean, several years ago, I had a patient come in, and the chief complaint was actually anxiety. And one of the things I have all my patients do is walk, and wasn't moving his left arm. So I sent him to one of the movement disorders neurologists, and actually he had Parkinson's disease, the beginnings of Parkinson's. So anxiety, like depression, can literally be the first symptom that we see. The other thing, as we've mentioned before, it can be comorbid with depression. Now, I wasn't able to find a really nice graph like I had for depression, but these are the diseases associated with anxiety. And I just want you to be aware that anxiety is very common in many medical diseases. So we see it just like depression in stroke. We see it in heart disease, but we also see it in diabetes, hyperthyroidism, where the thyroid is working too strongly, respiratory disorders, alcohol, drugs, medications, chronic pain, irritable bowel, and in some tumors. So anxiety is out there in many different diseases, not just Parkinson's disease and not just anxiety by itself. Once again, what are the possible populations that would come to us who have Parkinson's to anxiety or the etiology? One is it might be comorbid. So again, the person who's had anxiety since they were a teenager, something they've been treating their whole life, and they're going to have anxiety whether or not they have Parkinson's disease. Number two would be one of the patients with one of these other diseases I just talked to you about, like heart disease. They've had a heart attack, for example. The other one that's interesting is they might not have really anxiety, they might actually have depression. There's an anxious or an agitated depression we especially see in older adults. And that's basically an anxiety, but it's also a depression. So those might be the ones that are comorbid or that coexist with depression. But once again, we think that there might be anxiety in many of these cases, like the example I gave you. So someone who's never had anxiety, and it's the first symptom of their Parkinson's disease. And so these are patients where the anxiety is part of the pathophysiology of Parkinson's disease. And some of the evidence for that is the age of onset of anxiety, and particularly panic disorder, which is one of the types of anxiety we see in Parkinson's disease, is older than expected. So there's definitely going to be a population where the anxiety is part of the same mechanism that's causing the movement disorder in Parkinson's disease. So once again, let's review the official Diagnostic Statistical Manual. And what does it say? It says excessive worry and anxiety, apprehensive expectation, which I thought is kind of an interesting way to describe it, and the worry is hard to control. And then again, we've got these symptoms here. We need at least 3 of them. But then look at this. It cannot be due to a medical condition. So once again, they're kind of separating, and that's why I made the separation at the beginning, a psychiatric disorder of anxiety versus a neuropsychiatric disorder. Neuropsychiatric disorder meaning it's part of Parkinson's, the last example that I gave. Once again, we've got some challenges in diagnosing anxiety in Parkinson's disease, because some of the symptoms of Parkinson's may indeed look like, or I'm sorry, some of the symptoms that we look for in anxiety might look like just Parkinsonian symptoms. So what are those? First is akathisia, which is the motor restlessness that a person can get secondary to levodopa withdrawal. And that can look like some of the movement with the anxiety. Restless leg syndrome, which is often seen in Parkinson's disease. It's a sleep disorder where there's an uncomfortable feeling in the legs, happens especially at night. It's a daily occurrence where somebody has to literally get up, usually they're in a chair, and walk around to get some relief. And so that can be, again, mistaken. And then autonomic dysfunction. You can get excessive perspiration in Parkinson's disease. Well, with anxiety, you can start sweating also. But somebody could take these 3 symptoms and say, well, it's part of the Parkinson's disease, when in fact, it's part of the anxiety. So what are the common types of anxiety we see in Parkinson's disease? One is a generalized anxiety disorder, and that's closest to the DSM-5 diagnosis I showed earlier. The other one is social anxiety disorder, also known as social phobia. And this is discomfort among social interactions, concern about being embarrassed or judged by others. It's experienced as fear, as anxiety. It's often accompanied by an autonomic arousal. So that again is that perspiration. But an autonomic arousal can also include apnea, which is some shortness of breath, tremors, tachycardia, the heart beating quickly, and even nausea. And then the other one that's quite common is a panic disorder. And that's often results in people ending up in the emergency department because, as you know, panic disorders can sometimes appear as if someone's having a heart attack and should always be checked out to make sure it's not something cardiac. Once again, we're challenged as far as diagnosing anxiety. As with depression, there is no easy lab test that we can do. So we're relying once again on the face valid self-report measures, the questionnaires. We're hoping for more observer rating skills, but we definitely rely on the family caregiver and the structured interview, which again has the limitation because time can be an issue with that. So anxiety changes how people perceive the world. It can produce confusion and distortion of perception. So time and space, but also of persons and the meanings and events. Now this is important because in Parkinson's disease, some studies in Australia showed that in addition to the masking of the face, so with a masked face, you might have problems understanding how the person is feeling about something, whether they're angry, and sometimes the masking of the face has a stern look, or whether they're bored, and so on. But what they found in the studies that they've done is that people with Parkinson's with masking of the face also have difficulty interpreting other people's nonverbals. So again, you've got the anxiety, which is possibly causing some confusion, some distortion. And then you've got the inability to understand nonverbals. In other words, if I'm really mad at you and I give you a really angry look and you're not understanding what that means, that can cause all sorts of problems. So once again, if we've got anxiety, we want to treat the anxiety because the symptom from Parkinson's is made even worse by the anxiety being present. The other one is more cognitive, selectivity of attention. So anxious people sometimes just focus in on certain parts of their environment in a way to confirm why they're feeling so scared, so anxious. Problem in Parkinson's disease with the executive dysfunction is people can sometimes lose the ability to multitask. And so as a result, they're not able to see other options in the real world. Not only does this affect attention, but downstream it can affect things like concentration, new learning, for example. The other two are mostly just what anxiety does. One is rumination. So the need or desire to be alone, to just be with your thoughts, to deal with the anxiety. It takes people away from fun activities, which actually can sometimes be helpful. And ironically, a person's thoughts can be their own worst enemy. And then agoraphobia, the fear of being unable to escape. Someone that refuses to leave very few select environments, like home, for example. Again, isolation. So anxiety can exacerbate symptoms of Parkinson's disease. So the awareness, first of all, cognitively, the awareness of being frightened, along with some of the physiological sensations. So I'm starting to perspire all of a sudden. And are you noticing that? Maybe my hand's shaking a little bit. So what's happening here? I'm trying to present, and now I'm very anxious. And I'm focusing on what? I'm focusing on being nervous, being frightened, and some of these physical changes that are occurring, perspiration and so on. How much am I able to be in the moment with my talk, right? I'm going to be distracted. My attention concentration is going to be less than it should be. Cognitively, this can also affect real world situations like memory. So you're talking to me and all these things are happening to me, and maybe I hear 40% of what you tell me, and it's going to look like I have a memory problem, but actually it was the anxiety distracting me, an internal distraction. Physical changes can be an increase in tremor. So if I told you you've got to go give a talk right now to 500 people, here's some papers, go ahead and do a good job, there's a good chance when you're holding the paper, you're going to have a tremor, whether you have Parkinson's or not. And we have had patients come in where they have felt that their medication is no longer working adequately, and it's actually the anxiety has gone to the point where it's actually affecting their tremor. So we're not going to do anything with their Parkinson's meds. What we're going to do is we're going to treat the anxiety. It can cause excessive perspiration, which again can have problems socially and otherwise. And it can increase fatigue and interfere with sleep, just as depression can interfere with sleep, just as Parkinson's can interfere with sleep. So we want to be aware of those and to treat them. And we've got the same challenges when it comes to treatment of anxiety, but actually it's even a little bit worse. It's limited because most of the treatment comes from the randomized trials they've had for treatment of depression, where anxiety has been a secondary outcome. So what do we do? Well, we look for what we call reversible or modifiable factors. First thing is, what other disease do they have? Let's say they've had a heart attack. Do they have anxiety due to, cardiac disease, due to some other disease, hyperthyroidism? Let's get those under control. Let's work with their doctors. It may involve levodopa dosing strategies, because wearing off is sometimes what's going to be associated with anxiety. The one area that does have quite a lot of evidence behind it is cognitive behavioral therapy, CBT, and specifically using systematic desensitization. So stay tuned on treatment for anxiety. It's being worked on, but it's still in its infancy in a sense. And those are all my slides. So questions we'll take during the live chat and during the Q&A. So thank you very much for your time. I appreciate it. Have a good day. Good morning, and I want to thank the American Parkinson's Disease Association for the opportunity to speak and for presenting this excellent conference. I'm going to take questions now, and I've got one from an occupational therapist, Lindsay Butkus, and she said, I have had patients who have difficulty doing therapy due to anxiety about their diagnosis and what the future holds. How do you recommend we work on this? So that's a common question I get from patients is, what's the prognosis? What does this mean now that I've been diagnosed? And the one quote I always use is from one of my mentors: when you've seen one patient with Parkinson's disease, you've seen one patient with Parkinson's disease. The point being, everybody is different. Even though I've been talking about anxiety and I've been talking about depression, some patients will never experience that throughout having Parkinson's disease. So that would be number one. Number two, what I would do is start by really praising the patient for asking that question, for having, that awareness that they're feeling anxious about the diagnosis. What does this mean? And also that they're taking active steps to deal with it. I mean, occupational therapy can do so much for our patients. It's just huge. So I would let them know that. I would praise them about that. If they're having difficulty with the therapy, the other thing I'd want to make sure is, are they perhaps having a little bit of a memory issue or something? So they're anxious because they can't follow through on the steps that you're teaching them, the strategies to use, and so on. So I would look at those areas. And then, of course, I would make sure that if this is active clinical anxiety, that we get that treated. So that's how I would manage that. Then I've got one from Bill McKay. How can I find a therapist with expertise treating Parkinson's disease people? And that's an excellent question. Start with your movement disorder specialist and see if he or she can recommend some people. The other thing is there are people who are certified in treating Parkinson's disease, and these are usually speech therapists, physical therapists, occupational therapists. LSVT, the Lee Silverman Voice Therapy, is for speech. LSVT Big is for physical. So if you are seeking a therapist like that, I would look for certification. If you're seeing a primary care physician, go to the hospital website. You can call that rehab department and ask about that. If you're looking at therapists specifically for depression and anxiety, that can be a challenge. Like I said in the talk, even psychiatrists will sometimes say, I'm not able to treat depression and Parkinson's disease because they don't have the training in Parkinson's disease. And same thing with a psychologist or a social worker. So ideally, if there's someone who your doctor is connected with, who sees a lot of patients with Parkinson's disease, who's a psychiatrist or a therapist, that can be helpful. If you're really in an isolated area, like a rural area, if you've got somebody who seems good, and if they're willing to, go to the APDA website and other websites and become well informed about Parkinson's, that's wonderful. But you have to be careful. I had one patient who had just a really poor experience where the therapist, it was a husband and wife, and the therapist told the patient, if you don't start smiling, I'm not going to continue this therapy. And they had no idea about Parkinson's or masking of the face. So you're absolutely right. Ideally, you want somebody who's got experience, or at the very least, who's willing to learn about Parkinson's. Cindy Bitker asks, would you talk about depression in patients without a caregiver, single, living alone? So that's an area that is a concern. As I said during the talk, we're actually starting to use a loneliness scale that was developed at UCLA for all people just because of COVID. But we know that loneliness can also exacerbate some of the symptoms we see with depression. So it is an issue. It depends on a number of factors. Are there options for maybe increasing the social network? And here's where being involved with a social worker. So if there's a social worker who's involved in the movement disorders clinic, or a social worker the person can meet with, he or she can explore with the patients what are other possibilities so that you're not so alone. And what I'm also worried about if someone is alone is also just safety in general. What if they fall? Do they have one of those buttons that's an emergency device, that sort of thing? But I would start with a social worker. They are wonderful. They're key members of the team. And I would have them explore what are some options if you're feeling lonely. And does the loneliness represent something else, like what's going on right now with COVID? Question here, if I suffer from depression, am I more likely to have psychosis? So psychosis can involve things like hallucinations or illusions, and one can get psychosis with depression, but just because someone has depression does not mean they're going to get a psychosis. Now, one can also have what falls under psychosis technically, hallucinations, particularly and most frequently visual hallucinations in Parkinson's disease. And those are very manageable. You just need to let your primary care or your hopefully your movement disorder specialists know that you're having some difficulty with them. What's different than what we see in psychosis in psychiatry is that in Parkinson's disease, often people are aware that this is not real. They're usually not frightening. They're not telling them to do anything. They're usually just visual. They can be something that's not very formed, just something I see in the corner of my eye, or they can be very formed. I had one woman who told me of an example where she set the table because these children were in her dining room and she was setting the table for them to come and have lunch. And by golly, they didn't respond. And then we were able to laugh about it because she had insight into that. So I would talk to the movement disorders doctor and get that treated. But no, I would not say that that increases the risk. We've got a question from Bradford Kitchens. Would you give us some examples of SBT that is being studied? SBT, I'm not sure what is meant by SBT. Maybe you could put the question in again and ask that again. Unless, did you mean CBT? Cognitive behavioral therapy? But anyways, I'll wait for that. Another question, does this mean that in addition to my Parkinson's disease, I have to be worried about having depression and anxiety? On the contrary, this is another opportunity for treatment and for alleviating symptoms of Parkinson's disease. So being aware that you can have depression, and depression can cause slowed thinking, and the other things I listed, or anxiety, which can interfere with concentration, being aware of those, being aware that they're both very treatable, is an opportunity to actually, in a sense, improve your symptoms. So I would say it's, rather than it being a burden, it's good information. And of course, I'm preaching to the choir, right? Because you all are here, but it's good information because those are things that we can address and that we can work on to help improve how someone is doing cognitively and physically. The other big one is sleep. So 1 in 3 Americans has a sleep disorder. 2 out of 3 people with Parkinson's have a sleep disorder. Please do not ignore sleep problems. They're contributing to things like anxiety and depression, but they have so many other negative effects. Get sleep checked out. What can I do now to promote my mental health? So basically the same thing that you're hearing from your doctor for Parkinson's disease. What's the number one thing we can do now? It's exercise, physical exercise, for all the reasons. It gets more blood up to the brain. It increases our neurotrophic factors. We know it helps. It might help prevent or delay Alzheimer's. And I said in the talk, we're all at risk for Alzheimer's, not to be negative, but we are. At age 85, depending on the study you look at, 30 to 40% of people have Alzheimer's in the United States. Exercise helps with mental health. Exercise helps with sleep. We know sleep is related to things like depression, and exercise helps with Parkinson's disease. That would be the one thing you can do right now, exercise. There's some research going into diet. One of the things they're looking at is the MIND diet, which was developed at Rush Medical Center, and that involves the Mediterranean diet, and it also involves the DASH diet, which is a heart healthy. And now it looks like it's possible that it would help with Parkinson's as well. So those are the questions I have time to respond to. I want to thank everybody for coming today and wish you all the best. And please work closely with your movement disorder specialists to manage the problems that you're having. Take care, everyone.
Hi, everyone. I'm Milad Girgis, General Manager of Deep Brain Stimulation here at Boston Scientific. We're extremely excited to be part of this event and are confident that it will provide a sense of community engagement, inspiration, and education. At Boston Scientific, we are passionate and committed to the work that we're doing in the field of Parkinson's disease, and specifically in our therapy options for deep brain stimulation. If you'd like to learn more about our therapy solutions, please visit our website at www.dbsnme.com. Again, we are so excited to be a national partner in this event, and we truly wish you the best in health.
But I want to get you up in this break and get you moving a little bit and get your blood flowing. So everybody, let's get up. If you're sitting down, we're going to stand up nice and tall, and we're going to pull our shoulders back. I want you to take a nice deep breath in through the nose. Raise those arms up over your head, nice and tall, right by your ears, and blow that air out and bring your arms all the way down. All right, we're going to start moving our hands and our wrists and our arms. We're just going to take our hands right next to our shoulders, make a nice tight fist, punch out in front, open those fingers up, bring them back to your shoulders, and punch them down and open up those hands again. Fingers spread really wide to our shoulders, out to our shoulders, and down. Flicking those fingers open and making those fists really tight. Okay, so we want to feel all the joints in our fingers and our wrists and our hands. Make some big movements here. Keep those knees slightly bent. And just warm up those hands and arms. Just a few more here. This is really good if you have any kind of stiffness in your hands in the morning when you get up. These are a great way to get those hands warmed up. And your elbows and your shoulders. All right, now let's do a little bit of rotation in our feet and our hips. We're just going to start with our hands on our hips, and we're going to rotate one foot in and out. Doesn't matter which one you start with. You're just tapping that toe out and in. Now, keep those knees slightly bent and get a little bit wider rotation. Try to get that hip now involved, right? Not just the foot, but try to rotate that whole leg in and out, right at the hip. Your knee is bent. Now add that hand and arm in with it. So we're going to get a little rotation in our elbow and our wrist. All right, we're going to switch to the other side. So start with the foot, in and out, tapping that back and forth. Bring those toes up and around. Now get that hip involved a little bit more. Try to rotate that whole leg in and out. Our knees are slightly bent here, both knees. All right, add that hand and our arm here. So just warm up all those joints, right? In our elbow, in our knees, in our hips, and our ankles. Couple more. All right, let's bring it back to a nice standing position. Knees are slightly bent, shoulders are back. We're going to work those calves and ankles a little bit more, bringing up one foot at a time onto our toes. All right, so we keep those knees kind of bending back and forth. We're not actually picking our whole foot up off the floor, just our heels. So I'm going to show you from the side here. And I'm just going to swing those arms. Whatever feels naturally to you. This really gets that blood flowing all the way down the legs, pumping that blood up and down, getting our knees worked out here a little bit so they don't get stiff. All right, we're just going to punch in and out in front now. You can keep your hands in a fist, or you can open them up back and forth if you want. Flick them out some more. So I'm kind of flashing my hands, really working those fingers, spreading them really wide. And let's take it down to a nice standing position. We're going to finish with a nice deep breath in again, raising our arms up overhead by our ears and blowing it out. All right, have a great rest of your day with Congress. I hope you've learned everything you wanted to know. And please look for our YouTube videos. We come to you every week on YouTube. Just look for, go to APDA, Parkinson.org, and go to the Greater St. Louis chapter. I hope to see you there. Have a great rest of your day. Bye-bye now.
Hi, I'm Tiffany Turner. I'm a speech pathologist in Tulsa, Oklahoma, and I'm excited to be with you here today and talk a little bit about swallowing and voice and how they pertain to Parkinson's disease. So first, I'll start with just a little brief introduction about myself. Again, my name is Tiffany Turner. I'm a speech pathologist and also a board-certified swallowing specialist. So I have an additional certification in swallowing, and I'm the owner of a private practice clinic here in Oklahoma called Swallowing and Neurological Rehabilitation. So my team and I at our clinic, we do a lot of swallow studies and voice diagnostics, which I'll talk a little bit about today. And we do see a lot of patients with Parkinson's disease and even have a Parkinson's voice group Normally, it's been put a little bit on hold due to COVID, but we do work a lot with patients with Parkinson's, with swallowing and voice. So I'm excited to be here today and to share some of this information with you guys. I did graduate from Oklahoma State University with my undergrad and graduate degrees. And as I mentioned, started our clinic back in 2014. So our 7-year anniversary was actually last week. So SNR has been open 7 years, and we've been doing a lot with our local APDA chapter during that time, as far as, again, Parkinson's groups and that type of thing. So I'm happy to be here with you today. So we'll get started. First, we'll start just talking a little bit about how Parkinson's affects our swallowing and voice muscles. So in addition to Parkinson's disease, at the clinic, we treat a lot of other different types of conditions, like muscular dystrophy, other things like that. And in those conditions, the muscles themselves are actually getting progressively weaker. So atrophy is happening and those muscles are losing function. In those cases, we can't treat that as easily. So when the muscle itself is having atrophy, it's hard for us to exercise and regain that ability. With Parkinson's, however, it's a hypokinetic disorder, meaning reduced movement, as you probably are aware of. And so in that case, the muscle isn't moving to its full ability, but a lot of times with exercise and stimulation, and with that extra effort, it can still move fully. And so by doing those exercises and movements early on, we can prevent some of that atrophy that would otherwise happen. So the muscles aren't inherently weak like they are with a lot of other progressive conditions that we treat. But in this case, they just have that reduced movement component. But if you can, power through that and do exercises to keep those muscles moving, they can maintain better function for longer. And in some people, we can eliminate and postpone some of those swallowing and voice concerns. So exercise of our throat muscles is just as important as it is with the physical muscles in our body. So I'm sure a lot of you are familiar with, the boxing classes and cycling and all the physical exercise that, is advocated for with Parkinson's disease. So it's the same thing with our swallowing and voice muscles. We have to make sure that we're exercising and using them so that we can hang on to that function as long as we can. So first, I just want to point out some swallowing and voice kind of anatomy landmarks. So as we go through this today, I'm going to be talking about how we can assess swallowing and voice and how we can treat and exercise those particular muscles. But I think it just helps to have a visual of, what muscle are we talking about when we're talking about this exercise or this strategy. So I want to just point out a few basic landmarks first. So I'm going to go ahead and use the mouse here. And first we'll look at this picture on the left, and I want to point out a few things here. So this is the side view of the anatomy. And I'm going to point out some of the swallowing and voice structures. Swallowing and voice work together, so it's the same muscles involved in both. So we'll kind of talk about both of those together as we go. So looking at this side view, here's the tongue, and they are labeled too, but I'll kind of point out some things here. Then in our throat below that, we have 2 tubes that are important. That first tube in the front there is the trachea. That's our airway that leads to our lungs. So when we're breathing, the air comes up from our lungs through that front tube, and it vibrates our vocal cords, which is how we speak and get voicing. So here are the vocal cords. They're the door to the airway. So they actually sit at the top of that airway and vibrate when the air passes through. The back tube behind that here is the esophagus. So that is the tube that leads to our stomach. So when we swallow food or liquid, it should all go in that back tube toward our stomach. None of it should go in the front tube that leads to the lungs. If that happens, that's referred to as aspiration. And that is when we have a swallowing problem. You might occasionally feel like something went the wrong way. And we all do that occasionally, where we take a bite or a drink and maybe we're talking or distracted and we feel a little bit go down the wrong pipe. That would be if some of it's getting in that front tube that it shouldn't go in. So normally when we swallow, those vocal cords that I mentioned are the door to our airway. When we swallow, they close. They close off that airway so that nothing can go the wrong way. And then we also have this flap right here called the epiglottis, and it also flaps over and closes the airway. So we have those two forms of protection. Those vocal cords close and that flap closes. And then that front tube is sealed off when we swallow, and that back tube is controlled with a sphincter, and it opens to let all of the food in. So that's what we hope would happen in a normal swallow. So we'll kind of shift here and look at this picture on the right that gives us a little different view of it. And this will be the view that we'll look at moving forward as we talk about some of the exercises. So looking at this picture, down at the bottom where it says tongue, that is the front. And so we're looking front to back from the bottom to the top. So down at the bottom, that's the tongue. That's where the very back of our tongue connects in the throat. So we're looking way back where the back of the tongue connects. Right here is that flap, the epiglottis that we talked about. And these white pieces here are the two vocal cords. So again, they're the door to our airway. So the tube we're looking in below that is the trachea, the airway. So and then back here, I'll point this out first. Back here is the esophagus, which again is a sphincter. So normally that back tube is closed and it only opens when we swallow. So this picture here is how we look when we're just at rest. So right now, if you're just listening and you're sitting there just breathing, your vocal cords are open so you can breathe. When we speak, air comes through that bottom tube and the vocal cords come together and they meet in the middle and vibrate, and that's what produces our voice. But again, when we're breathing, they're just open. When we swallow, they come together and they tightly close in the middle, and then this flap, the epiglottis, also flaps back to cover it. And so the airway is completely sealed off for a split second while we swallow. So it's true we can't swallow and breathe at the same time. So that airway is closed, and then when that's closed, this back sphincter pulls open to let all of the food and liquid go in that back tube. So again, that's what we hope should happen, and all of that happens just very quickly. So as soon as you take a bite or drink, again, the vocal cords close, that epiglottis flaps over, and that back sphincter opens. And there are a lot of things that can go wrong if even one little piece there isn't working like it should. So, we talked about the vocal cords closing all the way. Sometimes in patients with Parkinson's, because of that reduced movement, they don't quite close all the way. There's a little gap there, and that can cause a little bit of food or liquid to go the wrong way. So sometimes we see that. Sometimes we have just overall reduced movement and strength of all of these muscles. So sometimes we don't have enough oomph to open up that back sphincter fully. And so we can have residue that just kind of sits in this area. So sometimes we'll have patients, swallow food or a pill on a swallow study, and we'll see that it just sticks either behind this flap or along that sphincter and just doesn't go in either tube because we didn't have enough strength to open that sphincter and push it down where it should go. So those are some of the things that can happen with swallowing. And again, voice and swallowing go hand in hand. So if those vocal cords aren't closing all the way and a little bit of food or liquid's going the wrong way, we're probably at that point noticing some voice symptoms as well, because we're not getting that full vocal cord closure for voicing either. So when we voice, those vocal cords should come all the way together and meet in the middle. But what we often see in our patients with Parkinson's is that we have vocal cord bowing. So they try to come together, and just like it sounds, there's a gap, they're bowed due to that reduced movement. And because of that, we have air escaping between them, and we can get that breathy, harsh voice that we often hear in people with Parkinson's. So again, the treatment for that is to keep those muscles moving fully so that they're meeting better and we can hang on to that good voice quality for longer. So I'm going to show you a few examples here. Okay, I talked about a little bit of this, but here's another picture, and then we'll look at a couple videos of kind of what that would look like on a real patient. So we already talked about the anatomy here, and this picture points out a few more structures. We have that epiglottis in the front, again, the trachea. These are the true vocal cords that I pointed out a minute ago. We have some tissue on the side here called the false vocal cords. And sometimes another thing that we see is if we have that bowing, that gap between our true vocal cords, that side tissue wants to help push because we're not getting enough closure of the vocal cords. And so we can strain. So sometimes our patients are trying so hard to be loud and to get a good strong voice that they're straining. And then we see that false tissue pushing so hard that it's occluding and covering up the true vocal cord tissue. And so that's what causes a really strained, harsh voice instead of the breathy voice that we might get if they're just not meeting. So again, lots of different things that could be happening. And really the only way to know that would be to look on a scope, which we'll talk about that, and see what exactly is happening with the vocal cords. So we kind of talked about this. And again, the most common voice complaints in our patients with Parkinson's are, the quiet volume because the vocal cords aren't meeting all the way, or that breathy, harsh sound from the strain and the true vocal cords not meeting all the way. So we hear a lot from our patients with Parkinson's that, oh, their spouse just has hearing loss. That's what the problem is. But really the volume is the number one complaint. And for some patients is even one of their earlier signs of Parkinson's. And so again, we talked a little bit about swallowing, about some of the different issues that can happen. Some of the locations I'll kind of point out that we can see some of those things. So again, if that epiglottis isn't closing and the vocal cords aren't closing, we can see food and liquid kind of going into that airway. And that would be aspiration that we talked about. Sometimes we can see things sticking, like I mentioned, which is called residue. So depending on what's going on, like sometimes if that flap just isn't moving well, residue can accumulate behind it, so kind of on the base of the tongue, and pills can stick there, that type of thing. These are all things that we can look for on a swallow study, and then we can individualize the exercises for each person based on what we see on that test. And, again, as I mentioned, aspiration happens to all of us occasionally. We've all had something go down the wrong pipe. It's really only a concern if it's happening chronically. So, if we drink a little bit and a little bit goes in our lungs can absorb a little bit of foreign material getting in them. But if it's happening all the time and our lungs are just filling up with things, then we're more likely to get pneumonia and have respiratory problems. So really with all of this, that's what we're trying to prevent. We want to keep our swallowing safe so that we're not developing pneumonia and respiratory issues from chronically having things get in our lungs that shouldn't be there. So we'll kind of talk, I'm going to break it up here into swallowing and then voice now. So now that we've kind of identified some of those anatomical things, I'll talk a little bit about swallowing specifically and how we can assess for swallowing problems. So when you first have trouble swallowing, what are some of those tests that take place? And then talk about what we can do with that information to provide individualized treatment. So some of the signs of difficulty swallowing. So again, we've talked about the anatomy, but as a patient, these are some of the signs that you might experience early on when you start to have trouble swallowing. There are different phases of swallowing. So the pictures I've been showing you were focused on the pharyngeal phase here in our throat. Swallowing, though, is a process from mouth to stomach. So we can have swallowing problems at any phase of the swallow. It can be an oral phase problem, which would be, we might have weakness in these jaw and lip muscles. Maybe we have trouble chewing up our food well and have pocketing in our cheeks. Food can kind of stick there if those muscles are weak. Sometimes we have trouble pushing the food back to initiate a swallow. Sometimes if our lip structures get a little bit weak there, we can have some saliva kind of dripping. Some of our patients, will notice drooling. That is a new concern for them. So those are some of those oral signs that we might notice. Then with pharyngeal, which is those muscles we've been talking about in our throat, some of the signs of dysphagia, which means difficulty swallowing, for that pharyngeal phase are listed here. But again, you might feel like food or pills are sticking. You could feel them going the wrong way, kind of that, sensation of something going down the wrong pipe. You could have coughing or clearing the throat when eating or drinking. So again, we talked about those vocal cords and how they should seal off that airway. If they're not sealed off and we have a little bit go the wrong way, our body's protective mechanism is that cough reflex. So if I took a drink and I swallowed wrong and a little bit went the wrong way, I would start coughing because I have a strong, healthy, normal cough response. So we would hope that if a little bit goes the wrong way, our body would trigger a cough, which is those vocal cords slamming together to eject whatever started to go the wrong way so that our body can prevent it from going in our lungs. So it's kind of like a backup. If something starts to go the wrong way, that cough is triggered and we can hopefully expel it before it goes to the lungs. Now, having said that, sometimes in patients with Parkinson's disease or other neurological conditions, that sensation component can be affected. So sometimes material can pass through the vocal cords and you might not feel it. And so we might not have that protective cough, which again could mean we are getting things in our lungs more than we are aware of. So in someone who has no sensory deficits, we would hopefully feel that and cough. But a lot of times people with Parkinson's disease don't necessarily feel that getting in there because of some sensory loss. And so that cough may not be triggering like it should. So there's kind of a bullet point about that at the bottom, that sometimes dysphagia, is silent. Sometimes aspiration's happening silently, meaning no cough or no overt signs that you can identify. And again, some other pharyngeal signs, could be requiring multiple attempts to swallow. So sometimes if we do have a lot of residue, we might see a patient's having to swallow 3, 4, 5, even up to 10 times per bite because they still feel some sticking, which is not practical for a meal. If you're having to swallow every bite that many times, you're probably going to get just tired of eating before you get full. And then that can lead into some nutrition issues and weight loss, which is sometimes what we see. So we want to keep swallowing as safe and efficient so that we can maximize that time that we're eating and be as efficient as possible with our nutrition intake. And the last sign listed there is that wet, gurgly voice quality. So again, those vocal cords are the key player in swallowing and voice. So if we are having a little bit of material kind of starting to go the wrong way when we're eating and drinking, it can kind of rest on those vocal cords. And then when we speak, we might have a gurgly sounding voice. And that could be another sign that we're having some swallowing trouble if we notice that wet, gurgly voice, particularly when we're eating and drinking. Okay. So we'll talk a little bit now about how we can diagnose these swallowing issues. So there are 2 main types of swallow studies, and which one you get will depend on what provider you see and what they have in the way of equipment and just what type of facility it is. So oftentimes hospitals do modified barium swallow studies because they have that X-ray equipment that they use for other parts of the body, and they go ahead and use that same equipment to do an X-ray swallow test there in the hospital. So some of you may have had that type of test where you're drinking barium and they're watching it on an X-ray view, watching those swallow muscles from the side view, and we'll look at a picture of that in a minute. And you eat and drink different things, and they watch it go down on the X-ray, and they can see, that flat moving, see if things are going into the right tube or the wrong tube. They can see if residue is sticking, all those types of things that we've been talking about. The other type of test listed on the left side of the screen here is an endoscopic swallow study. This is what we do at my clinic, and a lot of outpatient clinics do this type of exam. ENT offices do this type of exam, and some hospitals do as well, but a lot of hospitals do primarily the radiology type since they have that equipment there anyway in the hospital. So either one of them is good. They're both gold standards in the field, and both tests have been found to be highly accurate with each other as far as reliability and sensitivity. And they both are very good at detecting aspiration and penetration and residue and all these things. So both are good tests, and which one you might get would depend on who you're seeing probably. So the FEES test, which is the endoscopic test, is a small nasal endoscope. So it goes in the nose about 2 to 3 inches back. So it's a little wire that has a camera and a light on it, and it's threaded back again about 3 inches through the nose, and it's dangling above all of those structures that we've been talking about. So with that camera in place, the patient eats and drinks different foods, and we can watch them on the camera. We have that aerial view, kind of like we looked at on the other picture a minute ago, and we can watch the different food and liquids going down and see, again, if things are going the wrong way, if they're sticking. We can watch those vocal cords to see if they're closing all the way, see if that flap's closing, that type of thing. On the fees, we can differentiate left versus right since we are looking from above. So we might see, oh, that left vocal cord isn't quite moving to midline as much as the right one, or that type of thing. And we can also do a voice assessment at the same time. So there's a little bit different equipment. We can turn on a strobe light where we can see the vibration of the vocal cords and actually do a voice exam as well at the same time. Whereas the modified barium swallow study is a side x-ray view, watching the swallowing muscles that way. So again, it detects those same things with swallowing, except it can't differentiate right versus left since it's that side view. So just a little bit different test. And it's a little more limited in timing as well due to radiation exposure. So sometimes with those, they might only do a few trials, whereas the fees, the endoscope does not use radiation, so it can be a longer test. So sometimes, if we have patients who say, oh, this certain pill gives me trouble, or this particular food, we'll have them actually bring it in for the test, and we can, have them swallow as many things as they want while the camera's in, because there's no radiation, so there's no real time limit like there is with the modified barium swallow. So this slide just has pictures of both, again, to kind of compare. In this picture, I'll use the mouse here to kind of point out, this is the x-ray view. Right here, this wire that you see is actually the scope in place. So this is a picture, a simultaneous view of the scope in place while the patient is in the radiology suite. So this never happens in the real world, but it's just a neat demonstration picture to kind of compare the views for you. Typically, you would have either the scope or the radiology test, or maybe you would have both, but you wouldn't have them at the same time. You wouldn't be under radiology while the scope's in, but it's just to kind of give that side-by-side view. So this patient has taken a drink of white barium. So you can see the scope in place. On the x-ray view, we see some residue right here. So that barium is pooling there. It didn't go down like it should. And then we see some more residue here. And then this is that view from above, looking from the scope that's dangling from above. And we see that white barium right here. So this is behind that flap, behind the epiglottis, in a little notch called the vallecula, which is right here. So here's that flap from the side view. Here's the pooling there that's right here. And then we see some trickling back on the patient's right. So since we're looking from above, it is reversed. So the left side that we see is the patient's right side. So we can tell here that they have some pooling in that right piriform sinus, whereas on this view, we can see some pooling farther back here, but we can't tell if it's the left or right since we're looking from the side. So just a different view. But again, as you can see, both give us that same information about where things are pooling, etc. So those are the two types of swallow studies you might encounter. And then I have just a couple of video clips on that. Again, since I do fees, the endoscopic one is what we do at my clinic. Those are the examples that I have just here to kind of show you what that looks like. This first example is showing aspiration versus penetration. So on this one, again, if food starts to go over the wrong way, but it doesn't quite go all the way down, that's referred to as penetration. So sometimes we might swallow and then it starts to go the wrong way, but it goes the right way. That's penetration, versus aspiration is when it just all the way goes the wrong way. So I'm going to go ahead and show you a clip. Watch this. This is a peach that has green food coloring, just so we can see it easier on the camera. So there, it's starting to go over that flap, and then they swallowed. but then we look and we don't see the green in their airway. So that one was called penetration, meaning it got over that flap, but the vocal cords caught it and it did not go all the way the wrong way. Show you a couple other ones real quick and then we'll move on. It's wanting to play again. This is an example of just lots of residue. So as you can see, this person is swallowing multiple times, but they just have tons of residue accumulating. So that's a little later in the study. They have so much overall weakness that residue is just accumulating everywhere. So this person needs lots of treatment. Starting again here. And this last example is of reflux. That's another thing that we can see on a swallow study. So you'll see that the food goes down like it should. It goes in that back tube, but then watch for it to come back up. There, they swallowed. And that all looked normal. Now watch this back area. And we see it coming back up, and then they swallowed again. So that time the patient felt it and they swallowed again, but sometimes we can aspirate on reflux as well. Okay. Stop it here. And then this slide lists some of the different swallowing treatment options that are available. So again, it really does depend on what we see on that test. But depending on what is seen, there are exercises for those different muscles. There are also strategies and techniques. So if we see someone aspirating, we might have them try another bite and try a chin tuck or some type of technique that can help prevent aspiration. E-stim might be appropriate for some patients where electrodes are placed on the muscles to stimulate them. And sometimes different breathing exercises are necessary, particularly if those vocal cords aren't closing like they should. So there are a lot of different treatment options, but this is why it's so important to do a swallow study so we know what needs to be targeted. Okay, so we're running a little short on time, so I'm going to talk a little bit about voice now. A voice assessment is what takes place first before we know what we need to do in the way of treatment. So some of you may be familiar with LSVT Loud, the program that is for Parkinson's voice specifically. So with that or any type of voice assessment, we're taking voice measurements to measure our volume and our pitch and all of those things so that we can figure out, again, exactly what we need to target. So this slide kind of lists some of the things that might take place during that first visit. We might have you make some sounds, measure your volume, and measure your pitch and your conversational voice. And then again, we might want to do that endoscopy where we actually look at your vocal cords and see if they're closing all the way, etc. Every patient may not need to do this. If you've seen an ENT already, you may have already had something similar. So some patients will need this, some may not. And then with therapy, we always want to start the sooner the better. So kind of as I mentioned, you know, if we can get those muscles moving better earlier on and have you do exercises every day at home with your swallow and voice muscles, we can hopefully prevent some of that trouble later down the road. So we like to see patients, you know, even if you're not having any trouble with your voice yet, we can often do just one visit to teach you some exercises that can be done at home to kind of help you just keep those muscles stronger for longer. So prophylactic voice exercises are great as well. But even if you are having trouble, there's a lot of good treatment specifically for Parkinson's that can strengthen those muscles, as well as some groups that I mentioned, some Parkinson's group voice maintenance, you know, groups, which are good as well. And, you know, this whole presentation has been about swallowing and voice, but I just wanted to quickly mention, you know, speech pathologists also work with memory and cognition. Sometimes our patients with Parkinson's will develop a stutter. You know, sometimes there are other things affected. And so, you know, those things can be treated as well. The bottom line of all of this is just you would need an individual assessment to determine for you what the best treatment is. So main take-home points here. Swallowing and voice requires lots of tiny little muscles that work carefully in sync together. And any even slight impairment in the movement of those vocal cords or those swallowing muscles can really impact our voice and swallowing. But the good news is Parkinson's responds really well to exercise. So we can exercise those tiny little muscles just like our other muscles in the body and can make a lot of great gains. But the important thing is that treatment starts earlier versus later. It's much easier to keep those muscles strong and maintain swallowing and voice than it is to fix problems that have become severe, due to a long period of time of not addressing them. So it's important to seek help at the first signs that you notice of any swallowing or voice trouble, or with cognition or thinking or any of those other areas. And there is help available, and Parkinson's responds really well to exercise. So I want to encourage you that there is help available. If you have any questions, I'll be available for the Q&A here. So please jot down your questions and ask those. And I'm happy to help however I can and hopefully connect you to some resources. Hello. Okay, so we'll go ahead and answer some questions now. It looks like the first question is from Jim Oberg, so I'll go ahead and read that and then answer that. It says, at what point is tube feeding recommended? Once on 100% tube feed due to aspiration, is it ever possible to go back to regular food? And that's a great question. First of all, as far as at what point we would do that, this varies a lot from person to person and sometimes even from clinician to clinician and how we would treat that. But there are a lot of research studies that show that some people are functional aspirators. So some people are aspirating and things are getting in their lungs, but their body can fight off infection. So if it's just little amounts and we're not getting, pneumonia or infection from having that get in our lungs, there are people who aspirate for years and can get by relatively okay. There are other people who, their body doesn't fight that off as well, and they get pneumonia and have those breathing complications. And so it becomes unsafe to eat orally if they're constantly getting things in their lungs and it's causing those respiratory complications. But with regard to that, even if someone is placed on a feeding tube, it doesn't mean it is forever. We can absolutely strengthen those swallowing muscles and get back off of the feeding tube, at least to some extent. With Parkinson's, of course, it's progressive. However, it responds really well to exercise, like we've been talking about. And so, for a lot of people, if anything else is going on with our body, so maybe we're sick or fighting off something else, or we've been in the hospital, or for whatever reason, during times where our whole body is weak, those swallowing muscles will be weaker and fatigued as well. So there might be times where we need a feeding tube temporarily because things get really bad at a certain point. But then once that person is stronger and feeling better, they can regain strength and exercise those muscles. And absolutely, it is possible for some people to regain oral intake again, at least to some extent. They may not be able to get their full nutrition that way, but some people are able to get to a point where they can eat, what they want to for pleasure, and then maybe just supplement some in the tube or that sort of thing. So it depends on the person, but a lot of times, yes, that is possible. Okay, so our next question here, I don't want to mispronounce the name. It's from Prakash Purim. It says, I choke often on liquids and speak in whispers. I'm thinking of getting thyroplasty done so the cords don't bow anymore and will be hapless. Let's see. I haven't had pneumonia as of yet, nor any aspiration to rid the lungs that have any food in them. I have been through LSVT. Thanks. So that the procedure, the thyroplasty that she's talking about. So kind of like we talked about on the slides, we have that sometimes with Parkinson's, what we see is that gap between the vocal cords. So instead of coming all the way together, they get weak from not being used fully over time, and they start to have that little gap. And that thyroplasty is where the ENT can go in and inject one of the vocal cords, or sometimes both, to bulk them up so that they meet again at midline. And for some people, that can be a very helpful solution. There's some different materials that they can use to inject. Some of them last longer than others. So sometimes it's something that we're having to do, repeatedly every so often, because it doesn't last forever. And, it can cause other issues for some people. So it's not recommended for everyone, particularly if there are any breathing complications, because if we are injecting those vocal cords and kind of permanently moving them closer together, that is narrowing our airway a little bit. So normally when we breathe, those vocal cords open really wide, but they can't open as wide if they've been injected. So it can narrow our airway a little bit. And if people have any kind of respiratory problems, sometimes ENTs are hesitant to do that procedure for that person. So it just kind of depends. But again, particularly with Parkinson's, since we can get those muscles moving better with exercise, most physicians prefer to try that approach first before doing the injections, but it definitely is a good option for some people, and particularly if they have such a big gap between the vocal cords that even with exercise, they're not getting that good closure, then that might be someone who's a good candidate for that. And then we have another question here. It says, what can we do at home other than sing to exercise our voice? Great question. And there are some ways that you can exercise those vocal cords. And again, it's person specific in that there are a lot of different muscles involved and different things. And, even because we have Parkinson's and we know that probably we have some vocal cord bowing and some weakness, sometimes we can have, in addition to that, vocal nodules or other vocal things where exercise would be contraindicated. So I just want to be clear, it's not a one size fits all thing. But generally speaking, for most people with Parkinson's who don't have any other things going on with their voice, typically just some general vocal function exercises are good. And so a couple, I'll kind of tell you 3 common ones here that everyone can do at home generally pretty safely typically. So one good one is to take a deep breath in. So fill your lungs with air. And then on that full breath, we want to say, ah, for as long as we can hold that in a good volume and quality. So not just as long as we can. What we typically see with our patients when we're doing that exercise, and we'll be measuring their volume on the screen, and we'll see that as they're holding it out, their volume just goes down, down, down. And so what we want to focus on is keeping the volume up and keeping our voice quality good. So we would rather it be a little shorter and be good volume and quality than be really long, but it's just completely trailing off and we're practicing in that bad voice quality. So we want to hold that ah sound out as long as we can with good volume and good quality. And you can kind of time yourself. There are apps. There's one app called Voice Analyst that is an app some of our patients will use at home to measure themselves, and you can see your volume. So you can hold it in front of you and it graphs your volume, and you can see if it's steady or if it's decreasing, and kind of make sure you're maintaining it and self-monitor. And then the other 2 exercises along with that are pitch glides. So starting at that same ah, your regular voice. From there, we want to reach the highest pitch we can and then hold that out for a few seconds. So you can either stair step, ah, 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 or do a glide, ah, and reach that highest pitch and then hold that 3 to 5 seconds. And then same thing going low. So we want to start at our normal ah and either stair step or glide to the lowest pitch we can. And when we do that, as we go high in pitch, those vocal cords stretch and elongate. And when we go low, they shorten. So we're doing those just to give a good stretch to our vocal cords in both directions. And you can also, on that app I mentioned, Voice Analyst, you can measure pitch on that as well. So you can watch your pitch go up, 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 and down, down, down. And kind of see, it measures your pitch, and the number there gives you the hertz. So you can kind of see if you're improving with that or getting more of a stretch than you did when you first started them. Okay, let's see. So the next question from Jennifer Johnson. Hi, Jennifer. Says, if I am thinking that I may have issues with swallow or speech, how do I go about getting an appointment? Do I reach out to my doctor, PCP, or neurologist? And how do I find an LSVT therapist? So that's a good question. A lot of people don't know where to start with that. And so there are a lot of resources for Parkinson's, as many of you probably know about, with, like she mentioned, LSVT and some of the voice groups and those types of things. But these are, the therapy services are considered medical. And so we do typically, for most insurances, need a physician order to get that process started as far as an individual evaluation and treatment. So any physician can order that. So it can be your PCP or your neurologist or anyone who treats you regularly for the Parkinson's, and you've told them about your swallowing and voice or whatever problem it is you're having. They can send that order over to a speech pathologist near you to kind of get the ball rolling for an evaluation. And then that therapist can, depending if it's more swallowing or voice, can kind of come up with a game plan with you for that. And as far as LSVT, on their website, which is LSVT Global is their site, because LSVT Loud is the speech pathology program, and then there's LSVT Big, the PT kind of counterpart to that. But on the LSVT Global website, they have a directory of all the certified clinicians, so you can type in your zip code, your location, and see if there are any programs near you. And then you could ask your doctor, to refer to those places who do work with Parkinson's on a regular basis and have certifications in that particular program for Parkinson's. And we have another question that says, when should you seek advanced help for speech or swallowing problems? So again, really with this, ideally we would try and do some prophylactic exercises. So, if you're not having any problems at all, even in that case, it doesn't hurt to get some exercises going that you're just doing on your own at home. So a lot of the doctors we work with here will send patients to us who are newly diagnosed with Parkinson's, and we just meet with them one time and teach them some individualized swallowing and voice exercises that they can do, each day on their own at home to kind of prevent some of that weakness from occurring. So it's best to not let it get bad at all. However, even if, at any stage of the game, it's not too late to get treatment. So no matter how severe the problems are, again, there are different levels of treatment. So if we have severe swallowing problems, there are e-stims and other types of treatments for more severe things as well. So depending on what the symptoms are and what stage it is, there are different treatment options kind of at each stage of that. And let's see. And then Bradford Kitchens asks a question about whether APDA provides voice strengthening exercises. And, oh yeah, there we go. If they're available on the APDA website. And they are available at the APDA website, and we can go ahead and, I'll read the link here and maybe they'll put it on the screen. APDA/Parkinson.org/St.Louis. And that would be the St. Louis chapter, there. Or you can check your local APDA's website as well to find resources near you. And so again, there are a lot of the different groups like Loud for Life, and there are some other programs, some Speak Out, Loud Crowd groups. Those are for just maintenance and group practice. So not to replace individual treatment, but those are great, particularly if you've already had treatment or you're not really having any voice symptoms, just to keep those muscles moving well and exercise them. And we have one last question here. And it says, are there foods you recommend for successful eating? As far as foods, not in particular, it's best to eat just regular foods if we can. So if we start over modifying too soon, we're not making our muscles work as hard, and they can get weaker from doing that. So we don't want to baby those muscles. We want to keep them working hard. So keep eating regular foods. the best thing we can do is do an effortful swallow. So we tell our patients, swallow like you're swallowing a hard-boiled egg or a golf ball. So squeeze and swallow. So sometimes, you might feel like something's kind of sticking a little bit. We wouldn't want to necessarily just start avoiding those foods and go to pureed or blended up foods. It would be better to eat those foods and swallow 2 or 3 times per bite, squeezing really hard. And that way we're building up that strength of those muscles versus just accommodating and kind of letting them get weaker, if that makes sense. And again, that's just a general recommendation. It would depend on the person, but in general, we want to keep eating regular food as long as we can and swallow hard and keep those muscles working well. Okay, so that was the last question. Thank you all for attending this today, and I hope this was helpful to you. And if anybody has further questions or if I can help with anything, you're welcome to reach out to me as well by email or whatever is easiest. But thank you all.
Hi, I'm Dr. Linda Nabobi. I'm an assistant professor of clinical neurology at Weill Cornell Medical Center at the Parkinson's Disease Movement Disorders Institute. And I'll be giving a talk to you guys today about the state of Parkinson's disease in the care of African Americans. I'm very happy to be here today, and I hope that this will get some interest in people and start a conversation. I do not have any disclosures. The objectives of my talk are to, first of all, improve awareness on the racial disparities in Parkinson's disease by using evidence-based data to identify the deficiencies and quality gaps in care. And then the other part of my talk will briefly discuss some of the steps that I think we need to take to address health inequity in Parkinson's disease. Why are we having this conversation now? I think that, first of all, in the past year, the COVID-19 pandemic, it has served as an awakening for race inequity in healthcare. We're seeing several groups, ethnic groups, being disproportionately affected by this COVID-19 pandemic. And it has really shown us how social determinants can really affect health. And when it comes to the pandemic specifically, we've seen how things like household crowding, so the inability to safely quarantine. We've seen how people who are essential workers, who are often minorities, the front line and are more likely to be exposed to the virus. We've seen how lack of access to personal transportation, so depending on public transportation, affects certain groups. And then also access to primary care, and then on the supply of safety net public institutions for people to get access to care, and then lack of bed capacity in those institutions. And then there's also disproportionate loss of employment and health insurance. And the list can go on and on and on. I think that many of these different factors have led to many of the outcomes that we're seeing in this pandemic. This is a statement that I like when it comes to, it's a statement about health outcomes and racism. This is a statement by Dr. Kriya Perry, who is a fierce physician advocate for Black maternal health equity. Dr. Kriya Perry says, racism, not race, is a risk factor for health inequity. And I want you all to think about that as we go through this talk. The other point that happened, the other incident that's happened the past year that has brought these conversations to the forefront are the resurgence of the Black Lives Matter movement after the continued police killings of unarmed Black men and women, and many incidents that have occurred in our nation that have brought to light the racial injustices that continue to plague our country. I think that when we have these conversations about racism and race in healthcare, I think it's important to note how history has affected the outcomes that we're seeing today. Many factors such as colonialism, slavery, indigenous genocide, and in addition, many non-consensual medical experiments that have happened in the past that have led to a lack of trust that we see today. For example, the Tuskegee syphilis study, which many people have heard about, gynecological surgery on enslaved women without anesthesia, which many people have not heard about. And then there's also Henrietta Lacks, who many of you know about, whose cells were used without her consent. Eugenics has been used to target women of color, poor women, immigrants, and people who are mentally ill. But again, these are many of the factors that have led to lack of trust in healthcare institutions today. And then, in addition, even today, there is continued racial segregation of medical facilities. Many institutions have a Medicaid clinic, which Medicaid is dependent on by many minorities. So there are many factors that have been at play throughout history and continue to be at play today. We're going to talk about health inequity in Parkinson's disease in a brief introduction about Parkinson's. It's a neurodegenerative disorder that occurs due to loss of dopaminergic neurons in the brain. It affects usually an older population, about 1 to 2% of people over the age of 65. It affects men more than women in a 2-to-1 ratio. And the prevalence, based on studies that have been done, is that whites are most affected, and then Asians, and then Blacks. And we'll get more into this prevalence data that we use today. Some of the symptoms of the disease include a rest tremor, slowness of movements, rigidity, poor balance, and some non-motor symptoms are a reduced sense of smell, REM sleep behavior disorder, which is acting out your dreams, dysfunction of your autonomic nervous system, so things like fluctuating blood pressure, constipation, urinary problems, mood disorders, and cognitive decline. There is no cure for Parkinson's disease right now as we know it, but there are very many treatments that are available to treat the disease. This talk will focus on the racial disparities in Parkinson's disease with a focus on African Americans. And I say what we think we know because these are based on studies that I think there are a lot of biases in these studies, which I'm going to get into more. I do want to make a note that this talk will primarily discuss ethnic disparities in the United States. However, there are disparities all over the world, but I'll focus on the United States. We do know that in low to middle income countries, there is less access to Parkinson's disease medications and neurology services. In the sub-Saharan Africa, there are very few neurologists, and Parkinson's disease medications, they are unreliably supplied, and they can be expensive. In addition, I do want to also clarify that during this talk, when I use the terms Black or African American, I mean an individual of African ancestry living in the United States. So let's get into some of the data that we have. First, we'll look at what is the presence of Parkinson's disease minorities in neurology clinics. So many studies have looked at this. This is one study from 1972 that looked at the number of African-American patients in neurology and non-neurology clinics in Baltimore. And they found that the prevalence was only 5 to 9.4%. Another study that looked at veterans who were newly diagnosed with Parkinson's disease in the Los Angeles VA system, they found that the percentage of non-whites was 17 and then 83% for whites. And within that 17% group, only 6% were African-American, 8% were Hispanic, and 3% were Asian, 0.3% were African, Native American. And then the study that looked at veterans from this time from the Philadelphia VA, they recorded cases of Parkinson's disease, and they found, again, a low prevalence for African Americans, 22%. This is another study that was, again, performed at the University of Maryland in Baltimore. This was from 2003 to 2010, so more recent. And again, they found a very low prevalence of African Americans in their clinics, 6%. Mind you, this is in Baltimore, where the percentage of African Americans is about 60%. So there's a huge discrepancy. This is an analysis that I did quickly at Columbia University, which is located in Washington Heights, which is a very diverse neighborhood, ethnically diverse, and just to see what the percentage of patients were that we were serving. And again, not surprisingly, 89% of the patients at Columbia were white. 5.2% were African American and 4.3% were Asian. And this is in a neighborhood that's very diverse. So we've seen this pattern that there are very few minorities that are being seen in Parkinson's disease and neurology clinics. And this has been going on for several decades now. Now, when we look nationally, what is the utilization of neurologists by African Americans? A study has shown that among Medicare beneficiaries, African Americans are less likely to get neurologist care compared to whites. The number is at 43.3 compared to 50.7. Another study has shown that African Americans and Hispanics are 30 to 40% less likely to receive neurologist care for several neurological conditions compared to whites. These differences in access to care have major implications to getting timely and appropriate health care for minorities. And so when you look at these numbers, you start to wonder, does this mean that people, ethnic minorities, are less likely to have Parkinson's disease? Well, let's look at what the data shows. Okay, so now let's get into the prevalence and incidence of Parkinson's disease. Many studies have looked at this data specifically, and they all suggest that there is a lower prevalence or incidence of Parkinson's disease in African American populations compared to whites, and that may account for some of the differences that we've seen. The fact that we're not seeing enough African Americans in these clinics. Just to quickly go over some of these studies, this was in 1995. They looked at what the prevalence in Northern Manhattan was, and they found that African Americans had the lowest prevalence. All these numbers, by the way, are per 100,000. African Americans had the lowest prevalence compared to their white counterparts and Hispanics. However, they did find that incidence of Parkinson's disease was higher, much higher actually, for Black men compared to white men and Hispanic men. This is another study in Northern California, looking at incidence of Parkinson's disease. Here, they find that African Americans had the lowest incidence at 10.2 compared to the highest, Hispanics, at 16.6. A publication that looked at all the studies that have looked at prevalence and incidence rates of Parkinson's disease in Africa compared to European and Northern American populations, again, also found a lower prevalence and incidence. This is a study looking at Pennsylvania state Medicaid claims. They find that African Americans had the lowest incidence again compared to their white counterparts. And then another study looking at prevalence in U.S. Medicare beneficiaries above the age of 65, they found again that African Americans had the lowest prevalence compared to whites. And so why are we seeing these lower numbers in minorities, especially Blacks? It's important to note that the results of all of these studies that have been done, they are limited due to ascertainment bias. Basically, this bias is that they're getting everyone who do present to hospitals and to clinics and people who use Medicaid or Medicare. This is how all these studies get their numbers. And so the key thing to note is that people who do not come to care, the large group of people who do not have insurance, who do not go to hospitals, who don't go to clinics, they are completely excluded from these studies. And who are those people? For the most part, these are minority populations, people who are poor. And so if we're not studying incidence and prevalence of Parkinson's disease in those groups, then we're missing a whole population. And so we don't truly know the true numbers because we keep studying people who are coming to care. And it's important to also note that movement disorder specialists who see a good number of these people with Parkinson's, they tend to practice in large medical centers where most of these studies are conducted. And so that may also be missing a large number of people just based on the fact that we're selecting for populations who tend to come to these large medical centers. And then from a patient perspective, studies have been done to see from their perspective, what are the barriers to care? And one study has shown that African Americans and Chinese Americans are more likely to receive Parkinson's disease symptoms as a normal part of aging compared to their white counterparts. And so when they see their symptoms, they may not show up to care because they assume that this is just part of getting older. Another study also showed that African Americans, they're more likely to underreport their disability relative to their motor impairment. So if they have a symptom and they feel like this is not as serious, they may not report things, and hence diagnosis may be missed. And then the other study that was done in Northern Manhattan that actually showed a higher incidence of Parkinson's disease in Black men. One thought is that, the reduced survival rates in African Americans can affect the prevalence of Parkinson's disease as people get older. So if Black people are dying younger, we may not be able to see Parkinson's disease at an older age. I do want to highlight one study that I think was done very well. This is the Copiah County study. This was a study, it was a community-based study that was done in Copiah County, Mississippi. And Copiah County it has the same prevalence of Blacks and whites. It's equally racially divided. And so they went actually door to door to see what the prevalence of Parkinson's disease is. Instead of doing it in the hospital and then missing some people from the community, they actually went to people's homes to count and see how many people have Parkinson's. And not surprisingly, they find that the prevalence of Parkinson's disease is actually the same between whites and Blacks. And so this really tells us that we need to rethink the way that we're doing studies, that we should be going to the communities to do studies instead of doing studies in the hospital, and we may be missing a large population of people who don't come to hospitals. And then when they looked at everyone that they saw who had Parkinson's disease, they found that 40% of them had been previously undiagnosed. And among those people who were undiagnosed, African Americans were more likely to be undiagnosed compared to their white counterparts. And the numbers were 58 versus 32%. Now let's talk about disparities in access to care. Studies have shown that African Americans present at a later Parkinson's disease stage compared to their white counterparts. So when they come in, they're more likely to be disabled, they're showing up later, and they're more likely to underreport their disability, as I mentioned. And then another study has also shown that Blacks are less likely to be treated by a neurologist. And we know, based on this study, that people who are cared for by a neurologist are less likely to be placed in a nursing facility, they're less likely to have a hip fracture, and they have higher survival rates. So we know that getting care from a neurologist is really good. It prevents, morbidity outcomes. And so when we know that Black people are less likely to be treated by neurology, that's a clear health disparity there. Studies have also looked at disease characteristics in Black people compared to their white counterparts. This study has showed that African Americans have greater disability and disease severity compared to their white counterparts when they come for care. They also saw same findings for people who are lower socioeconomic status. And then another study has shown that dementia is most often diagnosed in African American patients at 78.2% compared to their white counterparts at 69%. Same was found in women. And studies have also shown that dementia dementia is associated with a greater likelihood of death. And then looking at medication use in Parkinson's disease, a study has shown, this is a study that looked at adherence to Parkinson's disease indicators of quality care. So they had a neurologist who managed people with Parkinson's disease, and basically they asked them, check off, this box if you did this for your patients. And these are all quality indicators that they check off. Did they prescribe them this medication? Are they getting physical therapy, etc.? And so they found that the quality, the adherence to the quality indicators of care were higher in non-Hispanic whites compared to non-whites, and the percentage was 71 versus 65%. The difference was greatest for depression treatment. Another study showed that African Americans are 4 times less likely than whites to be initiated on Parkinson's disease treatment after they were diagnosed, especially medications that are indicated for Parkinson's. Another study also shows something similar. African Americans are less likely to be prescribed Parkinson's disease medications, particularly the newer agents. However, they were more likely to be prescribed antipsychotics, which is something that's not favorable in Parkinson's disease. This is another study that showed that African Americans and patients who were not treated by a neurologist are less likely to be treated with Parkinson's disease medications. So we're clearly seeing a pattern here. Many studies are showing us that African Americans are not getting access to the medications they need, and they're not being seen by neurologists. And then let's look at surgery in Parkinson's disease. As you may or may not know, there are surgical procedures that are available to treat the symptoms of Parkinson's, deep brain stimulation being the most common one, but then there's also focused ultrasound. This was a review of all the hospital discharges from 1996 to 2000, looking at all the discharges for any Parkinson's disease surgery. And they showed that out of the almost 1,800 patients that received surgery for Parkinson's disease, 86% of them were white, 0.6% of them were African American, 8.4% Hispanic, 2.5% Asian and Pacific Islander, and 0.3% Native American. What a clear, huge discrepancy. This is another study that was done even more recently, and they found that only 0.1% of deep brain stimulation discharges were for African Americans, despite the fact that they were going to hospitals that predict use of deep brain stimulations, meaning urban teaching hospitals in areas with a higher than average density of neurologists. The other things that predicted non-use of deep brain stimulation was Medicaid use and higher comorbidity score. This is another study that showed that Blacks and Asian beneficiaries were considerably less likely to receive deep brain stimulation than white. These are Medicare beneficiaries than their white counterparts. And they also found that Medicare beneficiaries who were treated in minority-serving Parkinson's disease clinics were less likely to receive deep brain stimulation regardless of their race. And then finally, let's look at what is the data of enrollment of Parkinson's disease minorities in clinical trials and studies. So in general, historically, randomized clinical trials in Parkinson's disease have enrolled very low numbers of underrepresented minorities. And this lessens the ability for us to generalize therapeutic developments. A few examples. So this is a study in 2009. They basically looked at all published studies of Parkinson's disease trials over the past 20 years. And they found that only 17% of those studies reported race or ethnicity data. And then among those 17% of studies, they found that only 8% of them were non-white. And in this, it was 0.9% African American, 1.1% Hispanic, and 0.7% Asian. This is a more recent study that came out in 2020, just last year. And again, they looked at something similar. And again, they found that only 17.5% of these randomized controlled trials reported any race or ethnicity data. And of those that reported, only 0.2% were African American, only 0.64% were Hispanic, and then 21.44% were Asian. When they looked at all the studies, they found that 98% of the people enrolled in the studies were white. Why are we seeing many of these disparities? So far I've shown you a lot of data out there that's shown that there's clearly a disparity in access to care and quality of care for African Americans and other minorities with Parkinson's disease. This is a multi-tiered problem. And I like this chart here, which was created by a master's student at Columbia, Danielle Kipnis. Thank you for this slide. But she created this graph to show some of the different factors that could lead to the problems that we're seeing today. And let's start from the individual level. So that's the purple, some of the potential causes. These are all causes that have been studied. Okay, so from the individual level, there's mistrust of physicians and researchers based on historical incidents that have happened in the past. Asian expectations. So, African Americans maybe not thinking that their symptoms are related to a disease, but thinking that it's related to just aging. And then caregiver burden can be a major issue that can affect people not coming to care. And then when you look at the community level, what are some potential factors? Lack of social support and resources, lack of access to exercise, lack of appropriate enough income to be able to seek care. And then also racial, cultural milieu can affect that. Geographic location, not being close to institutions that have neurology access and Parkinson's disease access. And then when we go on the provider level, some things that we know affect access to care include implicit bias among physicians, poor communication, poor provider-patient interaction that can deter people from coming back to care, facility characteristics, and there's so many different things on the provider level that we can certainly work on to improve. And then when you go to the system level, I think this is where we can, impact the most change. But some of the things that have been studied include research bias, so selecting patients at institutions instead of going to communities to do research, history of racism, which I had mentioned earlier, misrepresentation of the prevalence and incidence, which I went through in one of my slides, access to a specialist, access to physical therapy, occupational therapy, a movement disorder specialist, a neurosurgeon, all these things. And so many other factors, but all these lead to where we're seeing low numbers of African Americans and other minorities in clinic. And this leads to poor quality of care, late diagnosis or missed detection and diagnosis of Parkinson's disease, decreased access to medications, and the list goes on and on and on. But, we've spent a lot of time talking about the problem. Okay, we are here to talk about, have a conversation of what can we do about it and how do we move forward. Okay, so what can we do? A few potential solutions that I have thought about and other people have also commented on is that the first big thing is that we need to improve knowledge and awareness of Parkinson's disease among people in individuals and communities, among clinicians who don't treat Parkinson's, who are not experts in Parkinson's in institutions and nationally. However, any education that's provided should be targeted in a culturally sensitive way to the community you're trying to educate. So there needs to be community and education programs and campaigns to increase literacy in Parkinson's disease. And this should be through community centers, churches, and other religious organizations that serve these communities that we want to learn about Parkinson's. Building relationships with community leaders who have access to African American populations, and reaching informal gatekeepers, people who are trusted in African American communities. I think that's one way to start having the conversation and improving knowledge and awareness of Parkinson's disease. And I think there should be more education of primary care physicians and general practitioners. About only 40% of people who have Parkinson's are being seen by movement disorder doctors. The rest of people who have Parkinson's are being seen by community physicians, general practitioners in the community. And not so that they don't know what they're doing, but it would be good to keep them educated by other neurologists, by movement disorder specialists, so that they are on top of what's newest and latest in Parkinson's disease treatment, so they can provide the best quality of care to the patients that they're seeing. I think that it's also important to ensure that patients who come to minority-serving clinics, usually Medicaid clinics, which often are African American, Hispanic patients, people who cannot afford health insurance. It's important to make sure that all of these individuals are included in any community outreach, patient engagement initiatives that are being done for other individuals who are at the large academic institutions. And then the other end, other things that we can do are to create targeted strategies to improve inclusivity in research. As we can see, the dire underrepresentation of minorities in research. Most of the research that's being done include mainly white patients. So we need to fix that and make sure that anything that's created from research, we can be able to generalize it to any population. So it's important for us to have a diversity in our research. I do want to highlight a community-based participatory research. This is a research approach where you do research instead of going to a community and just studying them. You do research with them, and so from the beginning, you approach your community and you ask them, what can we do, and you discuss the research question together. You come up with the methodology together. You conduct the research together. You analyze data together, and you disseminate the results together. And that way, the community is benefiting from you, and you're benefiting from the community. But I think this is an approach that people should start taking when they try to conduct research. And then, make sure you have a culturally sensitive plan of outreach. You have to go to the people where they are. Many examples of how people have been able to reach African American populations are through churches, barbershops, farmers markets, youth centers, mobile health, community centers. So you need to be think differently about how to approach these communities, because it may not be the traditional way that you've always done before. It's important to make a conscious effort to discuss research and clinical trials with all patients, regardless of their ethnicity, socioeconomic status, health literacy, and not assume that someone who would not be interested in research. It's important to have research coordinator at minority serving clinics where patients are mainly Medicaid patients or people who are ethnic minorities. And then, going back to American Parkinson's Disease Association, which is the conference we're here for today. American Parkinson's Disease Association, they provide outstanding patient services and educational programs, and they elevate public awareness about Parkinson's disease, and they support research designed to unlock the mysteries of this disease. I like many of their programs, and I send many of my patients to their programs, and the goal is to make sure that everyone has access to all these excellent programs that have been created. With the evidence of the data that there's poor access to care for African Americans and other minorities with Parkinson's disease, APDA wants to be inclusive and equitable, and is currently working developing specific outreach efforts to underrepresented groups. And having this conversation today with you guys is one of the ways that we are going to get the conversation started and talk about ways to build a relationship with African American communities and improve knowledge and awareness of Parkinson's disease, and hopefully start to close the gap in access to care for African Americans and other minorities. I do want to highlight the APDA Diversity in Parkinson's Disease Research Conference that happened in 2019. This was an excellent conference where this was the first ever diversity conference that APDA has had, and it brought together so many people from different walks of life, patients, caregivers, clinicians, and the goal of the conference was to address this urgent and needs surrounding lack of diversity in Parkinson's disease care. And one good thing that came out of this project is a research grant to address lack of diversity in care and the health disparities in Parkinson's disease care. This is more information about the research grant that just came out. That was my last slide. I do really appreciate you all listening to me for this talk, and I look forward to getting your questions and continuing this conversation and getting suggestions on how we can continue to improve access to care for African Americans and other minorities. Thank you all for listening to me.
Hi, everyone. Thank you so much for listening to that talk. I hope that was interesting for you all. I'm really happy to be here today, and thank you to APDA for the opportunity to have this conversation. So we do have a question. This is from Melissa. As a neurologist who is white, is there a way to build better trust among my Black patients? That's a very good question, Melissa. I think that one of the first things is to get to know your patients and get to know where they're coming from, understand their culture. And if there's any hesitation as to, treatments or about the disease, I think it's important to understand where hesitation is coming from, understand the history of things that have affected Black people in medicine in the United States, understand what experiences they have had in their lives recently with the healthcare system that is causing them to have hesitancy or the lack of trust in the care that you're providing or other people are providing. But I think, first of all, that understanding, seeing where they're coming from, and then going from there. But they want to be heard and they want to know that you're on their side. And then when they provide you suggestions as to, okay, this is how I do things, work with them. Because as we've seen, not everything works for everyone. Okay, your white patients may follow certain rules and standards, but for your Black patients, it's a different culture. And I think just understanding your patients first would be the first big thing, and then go from there. Let's see, and then Melissa has let's see, Manon Day has a question. What needs to be done to get Black people diagnosed with Parkinson's? I have juvenile Parkinson's. It took a decade to get diagnosed correctly. I was diagnosed at age 27. I am African American. So the question is, what needs to be done to get Black people diagnosed with Parkinson's? Thank you so much for sharing that comment about your personal story. Unfortunately, we see this often that African Americans, Black people, are diagnosed years after their symptom onsets. And when they do show up, they are more debilitated. I saw someone recently who had the disease for at least 10 years, and they were coming to see me for the first time, and they're in a wheelchair because no one realized that this was Parkinson's disease. So it's not uncommon that we see this story. Now, how can we make this better? What can we do? Studies have shown that there are different reasons. One is, a reduced knowledge and awareness about Parkinson's disease. So I think one first big thing to do is to make sure that people in the community are getting educated about Parkinson's disease. And the fact that, Parkinson's disease, many of the symptoms look like someone just getting older. If you see someone who's shaken or looks slow or stooped, and, someone may just assume, oh, grandma is just shaken, or they're just getting old. And, they don't realize that this could be a disease that the person is dealing with. So the first key is, having people recognize that these symptoms are signs of Parkinson's disease, and educating people about that. The same way that you've seen a lot of education about stroke, recognizing the symptoms of stroke, people should start recognizing the symptoms of Parkinson's. Now, the question is, how do we do this education? That's the key. And I think it's important that this is approached through a community-based approach, going to where people are, such as churches, markets, barbershops. Many of these have been used in the past, community centers, going to people where they feel comfortable to accept the education. So I think education is one big thing. And then the other big thing is that studies need to be improved. Many studies, for the most part, as you've seen in my talk, 90-something% of the patients that are used in studies are white. And so when you're reading these studies, you're a clinician reading the studies, or you're a student, you start assuming that probably it's only white people that get Parkinson's. We need to change that. We need to start having more African Americans and other minorities recruited into studies, because when you see these numbers and start to realize, oh, it does also affect Black people. When you see a patient come into your office, you're not going to think, oh, there's no way this can be Parkinson's because they're Black. But having more African Americans in studies will teach students and clinicians that it does affect Black people, so that they can be able to recognize it and not ignore it when they see a Black person come into their clinic with a tremor or slowness of movements. So those are, I've mentioned 3 ways so far, but I really believe in the power of community work, community approaches, going into the community, going to the people. We do know that healthcare institutions have not been able to prove their trust, and that's one of the reasons we're not seeing African Americans and other minority groups come into these institutions. So we need to go into the community and build that trust back again with African American communities. And that way help improve the awareness about Parkinson's, and also help improve diagnosis and early access to care. And an emailer asked, so much to do, where do you suggest starting? That is a loaded question. Where do we start? So I gave different suggestions, and I think that if you try and do everything at once, you get overwhelmed. I think that anyone trying to help, you should look at your community, you should look at what you're surrounded by and find ways to help. One way that I personally did was doing, a farmer's market project where I saw that, we had a large Hispanic population by the hospital that attended the farmer's market, but we weren't seeing them in the hospital. And my idea was to go to the farmer's market and do education and let people know what neurology is about, what Parkinson's disease is about, and have them, understand that we're there for them in the hospital. And if they have these types of problems, they should come see us. But I think the first thing is, just look at your environment and think, what can I do? What can I do differently? If you're someone who's in policy and you're in DC, then, start doing advocacy for Parkinson's disease and improving access to care. Advocacy for having more, Black neurologists, Black physicians, advocacy for reimbursing physicians more through, with Medicaid, Medicare, so that they can provide care for these patients, these minorities, many of whom depend on Medicaid, Medicare. What else can we do? Research. Like I said, we need to just recruit more African Americans and other minority populations in research. There are different ways to do. There's no one way to start. I would say look around you and see what you can do in your community, in your line of work, and then go from there. And then make sure that you're having a conversation with your colleagues and other people to be aware that this is a problem. When you look around in your clinic, in your practice, wherever you are, and all your patients are white, that should bother you because that's not what America looks like. Christine Eason asks, I live in a community that has many neighborhood pockets containing healthcare deserts with little access to care, treatment, and information. Often people are not aware nor they can access care. How specifically can we effectively reach this population with resources? What community messages do we need to consider? That's a very good question, and that is a big problem right now that many people are facing. Many organizations, such as the American Parkinson's Association, have all these amazing resources that they've put so much time and effort and money to put together for Parkinson's disease patients to improve their lives. However, we know that access to those resources are limited for certain people who are in deserts or maybe don't have internet access or don't have access to physicians. And so I think one of the main big ways is to take that information that we've spent all this money and all these resources to create and take it to the people that need it. Now you have to come up with creative ways on how to do that. For example, if there's a church that brings that community together in that town where that's a desert, then partner with that church, because that's a very a key way to reach all these different people that you're not able to reach. Go to the church physically if you have to, and tell them that you're trying to improve access. And so that's one thing. Find a community center where these people that have poor access to care go to, and partner with that community center. Find stakeholders in the community, people who are trusted, and go to them and tell them, this is what I'm trying to do. I want to work with you. I want to help the community and see, and what do they need? This is what I have. How can we work together to improve education for community and also provide other resources the community may need? So the main answer is go to those communities. You have to go into those deserts and partner with people who are already trusted and who have access to these individuals that otherwise would not have access to all this information that you've created. That would be one way that I think that can be done. I have another question here. What can a person with Parkinson's disease who is white do to help the health disparities that you are talking about? That's a very, very good question. So a person who with Parkinson's disease who is interested in doing more, I'm going to assume that this person is already tied into organizations that provide resources for people with Parkinson's. Maybe they're part of a support group. Maybe they're part of an exercise class. I'm assuming that this person is tied in somehow into the Parkinson's disease organizations and community if they're asking this question. Now, what I think you can do individually is to look around in those different pockets of support groups that you have and networks that you have in your Parkinson's disease community, and look around you. And if everyone is white and you're not seeing African Americans, then that tells you, okay, we have a problem. And then the next thing you're going to do is to talk to the organization that you're working with, your support group, your exercise group, and ask, how can we spread this so that more African Americans are joining, what we're doing already. A good resource is your Parkinson's disease doctor, and tell them, hey, we want to improve the diversity of what we're doing. I have this exercise class that I go to, and I want to see more African Americans come. Can you share, this pamphlet with, your African American patients? We want to make sure that we're getting more diversity. If you're organizing a Parkinson's disease walk, and it's all you and all your white Parkinson's disease friends, well, you want to reach out and ask your resources, well, how do we find more patients? I think it's just about, first of all, being aware that it's a problem, that Black people are not accessing the same resources that you're accessing. Being aware of that, that's the first key. And I hope my talk has shown you that. And then reaching out to people in your network and trying to find ways to connect more with the African American community. If you all come together and you reach out to organizations and say, I want to do this, and then, connect with churches and community centers and groups, and, speak to your doctor, your physical therapist, all those people that you formed a network with and relationships with, tell them, I want to do this, and you're going to find ways to reach the community. And make sure that you're coming in from a place of care and from a place of understanding, and don't come in as, I'm coming to save you. Black people do not want that. Come in from a place of understanding, and make sure you're listening to the people that you're trying to help, and say, hey, we have this resource. I would love for you to come join us, and come from a place of humbleness and honesty. I think that'll be one very, very important thing. Do not come from a place of, I have this and that I can give you. Okay. But I hope that answers the question. An emailer asked, what would one way to increase clinical trial participation among Black people be? To ask people with PD who are Black, who have already participated in clinical trials, to talk with others. I'm going to read that to myself again. Would one way, got it. Yes, so I think one way to increase clinical trial participation among Black people is to have other Black people who have participated in other clinical trials come and speak to other Black patients and tell them about their experience. I think that's one good idea, because when you see someone who looks like you who's participating and they tell you, this is a great idea, this is how I benefited from it, this is how it's going to benefit science, and they weren't experimenting on me. That's one fear that many Black people have based on historical events, and share their experiences. I think that would be an excellent way. So if you have a Black patient in your practice who has done clinical trials, you can have them be a part of a support group for other Black patients and to explain what the experience was. I think, let's see, I think I have one more question. Do you see research grant funding as a barrier to access? Do we need more funding for studies that are more diverse? Absolutely. Studies have shown that research that deals with healthcare disparities issues are less funded, actually, and the NIH is actually working to improve this. So yes, it is a barrier, and we definitely do need more funding for studies that are more diverse. That is the last question that I would take for now. I'm really happy that I was here today. Thank you guys for all these really excellent questions, and thank you to APDA for having me join this forum today. Thank you all.
Hello, I am Roger Halleen, the president of the American Parkinson's Disease Association's Midwest chapter. And on behalf of the APDA, I would like to thank you for taking time to watch the Midwest Congress. I would also like to thank the Greater St. Louis chapter of the American Parkinson's Disease Association, the Oklahoma chapter, and of course, our Midwest chapter, for sponsoring this event. I'd also like to take the time to thank our speakers. I believe they were all wonderful, and I hope you were able to take something away from them that you can use on your journey with Parkinson's. I would also like to take this time to thank our sponsors, our champion sponsors, the James and Allison's Bates Foundation, the JCA Charitable Foundation, and Synovian. Our collaborator sponsors for this event were AbbVie, Acadia Pharmaceutical, Adamas, Boston Scientific, Delta Dental of Missouri, Kyowa Kirin, Medtronics, and Amneal. I hope that during the Congress you were able to take time to visit their pages and see what they have to offer for you and your journey with Parkinson's. If you weren't, please follow up in the future with them. I would also like you to take time to visit the American Parkinson's Disease Association's website and check out all the fabulous programs and educational material that they have available for you. Once again, it was fantastic to spend the last 2 days with you, and I thank you for taking your time. I thank our sponsors and our speakers, and we look forward to seeing you again in the future, hopefully in person.